And today's webinar will focus on this new educational series, and it's called Living Well Beyond COVID-19, Novel Patient Education Materials. And I have the pleasure of presenting this program along with Mike Bovan, my good friend, and he's an expert, and I'll introduce him formally in a second. This program has been made possible by the sponsorship from AstraZeneca, GSK, Moderna, and Pfizer. Now onward with the program. So I have the pleasure of presenting this program with Mike. And for those that know Mike, he's a clinical pharmacist, he's a consultant, he's an education developer and president of ComPharm Consulting Inc. And he has developed in excess of 500 accredited continuing educational programs for pharmacists, family physicians, specialists, and allied healthcare professionals. I think, Mike, that's an underestimate, actually. It's probably closer to 1,000.
I think we've done 500 on COVID ourselves, right?
Exactly, exactly. I think, you are now known as the encyclopedia for COVID-19. So thanks very much, Mike, for joining us today.
Pleasure to be here, Peter.
Yeah, no, this is wonderful. So I think what we'll do is the purpose of this program is to introduce you to the materials that are available for your patients. And we'll go through some of the questions and frustrations that people have. So maybe we could click through some of our slides now, and we might not provide you with all the answers today, but we will definitely direct you in the right direction as to where to get those answers. So these are my conflict of interest and Mike's conflict of interest. We worked with many companies before in education. Next slide, please, Mike. Disclosure of financial support, and we said there is sponsorship from AstraZeneca, GSK, Moderna, and Pfizer. We may be mentioning things as we're discussing things, but certainly it'll be sort of categories of medications or anything like that we're talking about. This program deals with COVID-19. Any treatments that we mention will be class and based on evidence and recommendations from guidelines. Program objectives are very straightforward. Appropriately and effectively use this new tool that we have. So this Living Beyond COVID-19 educational materials so that we can have patients understand COVID and a place where they can get proper information. And we want to identify the appropriate target population for each module, the prevention module, the treatment module, and also the long COVID module. And really, we want to help people implement some of the data that we have and some of the strategies because now it's kind of becoming a little bit sort of distorted or the focus isn't quite there. And yet we still have a lot of patients suffering. So we do need to help them in this fashion. Next slide. So the agenda is very straightforward for this evening. We'll introduce you to the Living Well Beyond COVID-19 series. We'll use this series with your patients. In other words, we're going to show you one case example of how this might be able to help you identify patients at risk. And then we'll direct you to the resources that you can then use for your patient. So introduction of this program. Next slide. So let's just do the first polling question to find out who is online. So please fill in what most appropriately describes you. I am a nurse, I'm a respiratory therapist, I'm other allied healthcare professional, I'm a physician, I'm a pharmacist, I work in the area of COVID-19, etc. So please put that all on there. And unfortunately, I think pharmacists has been lumped into the other types of allied healthcare professionals.
I've been called other many times before.
Yeah. I think this is a typo in omission because I know that the pharmacists have been the cornerstone. And Mike, you have been a knowledge fountain, but I know that the pharmacists that were working in community pharmacies, basically they were the only people that were open during the pandemic. So pretty much the physician closed up shop and the only light that was still on was the pharmacist. So thank you very much to the pharmacists and all the other people that work so hard. So we could see the spread that's coming in here. So we have lots of respiratory therapists. We have many other allied health. I'm assuming many pharmacists are in that bucket. We have lots of nurses here, some physicians, and some other as well. We don't seem to have a lot of patients in terms of long COVID, but certainly this program is geared towards patients as well. Next slide, please, Mike.
So, Peter, it's been interesting to watch as we've gone through this pandemic since, it seems like forever in the last bit. We've hundreds of millions of individuals across the world have been infected by it. I think at last count, we're about 7 million documented deaths worldwide, 1 million of those within the US alone. So significant, and the fatigue that you and I are seeing, and the fatigue that we're seeing for people every day. I was out talking to a group of people, and they kept looking and said, I had a breakthrough infection in my husband, and he's already had 4 vaccines. I've only had 3, and my friends only had 2, and this has happened. So that fatigue is coming up, and we're seeing that consistently across the board. But the interesting part is the good thing that we can say is what we're seeing more consistently is that if you are generally healthy and you're younger, you know what, most of these patients from a acute illness perspective have actually had relatively milder components if they're truly vaccinated across Canada, and we're seeing less of that impact. Unfortunately, for patients with complex comorbidities, as many of these respiratory therapists see on a consistent basis, and as well as our older patients, so that 60, 70, or 80 and above are going to be at much higher risk of severe outcomes associated with it. Anybody can get it, but as we know, higher risk of complications of death. And one of the key things that we look at for what are those comorbidities that we typically see, immunocompromised patients, anybody who's on a biologic for any of those advanced diseases that like rheumatoid arthritis, MS, that we'd see oncology patients. But the way that I describe it to patients is really heart, lungs, kidneys, liver, are all, and diabetes are all going to put those patients at elevated risk. So these are patients that, as clinicians, that we see regularly and consistently in practice. Long-lasting symptoms, long COVID, you know, the amount of patients that have long COVID and what is the formal number, it can range dramatically. We know the sicker that you were when you ended up getting COVID, the higher your risk of developing. And so if you were in hospital, you're an elevated risk. If you're hospital plus ICU, you're at elevated risk. And if you're on respirator, elevated risk of having prolonged symptoms for these patients. Or for some reason, some patients have mild acute COVID that never seems to go away. You'll see this even from clinical practice, is that patients will say, you know, they don't formally say they have long COVID, but they said, you know, I just don't have the energy that I did even a year ago. So it's what is really truly happening to those populations. It's a constantly changing topic. And I know, Peter, you've done quite a bit of work on long COVID as well. Impact of it is consistent. We see financial, physical, social, emotional, and strain on our already fragile healthcare system. And one of the things that we've said to people about, you know, flu shots, pneumococcal vaccines, COVID vaccines is the last place you want to be right now is the hospital. Please just get yourself protected, and we'll make sure that we can lower your overall risk. So, Peter, we've had some questions that people filled in regarding COVID-19 and what patients are asking about, and some of the things that they weren't necessarily there to answer, or confident enough to answer. So the first question is, how many vaccines do I need? Will the COVID booster be yearly like the flu shot? I'll take the second part is, what do you usually say if somebody says, how many vaccines do I need?
Yeah, no, that's an important question, right? So in other words, all of our patients are saying, I've had 3, I've had 4, I've had 5. And so the question is, do I have to continue to be a pincushion for 6 months? And there's a lot of people talking about these things. And these are some of the questions that I think our participants for this program actually typed in, right? So this is kind of like our needs assessment for you. And so therefore we deal with that in a living document. In other words, in this sort of modules that we're going to talk to you about. And then getting COVID, should I always get tested? So let's say I have cold symptoms. Do I need to do a swab for COVID? Are we going to be swabbing for RSV and flu and things like that? There are now combination test kits available where with one sample we can give you, let's say, whether you have flu, RSV, or those or COVID. So that might be useful kind of things that we keep an eye out. How sick will I be? Should I get it? Because there's been a lot of things saying, well, actually, it was just like a cold. I didn't really have a whole lot. And some people are asymptomatic. And then yet we still have people with very severe disease, and we still have death rates coming from it. We might not be reporting it, but then it's still happening. So therefore, we do have to identify these people at higher risk. Some strategies on how to best recover, so a person's been infected, and then they try to recover and they're finding no energy, those kinds of things. So some of these patients may not qualify as being long COVID yet, but these are, I guess, short COVID during that period of time. How do we make sure that they get better? And then comorbidities. So what should I do if I have COPD and COVID, if I have diabetes and COVID, if I have, so not your traditional immunocompromised cancer kind of immunotherapy kind of patients, but just general patients that we have. And there's a lot of questions about what will happen to those people as we move forward in this pandemic that people think is gone, but yet we're still seeing these people.
Yeah, and the question about, are we going to go to a yearly booster? And this is a question that was front and center, actually, that's happening within the US. And they're very transparent in terms of all their meetings, so you can listen in, but The unfortunate part is we really don't know. And I think that's the ultimate goal, is that we want to go to an annual basis. And one of the conversations that I've seen in the US is we have to meet our patients where they are. We're simply, it's getting harder and harder to get people back to come in every 6 months to get a vaccine, especially the ones at elevated risk. There is more talk to getting to that annual one. And as we see the demographics or really the prevalence of this disease or this virus change, it will change in terms of the overall components. I just want to really quickly comment on COPD and COVID-19. I know there's a lot of respiratory therapists. It's very concerning for these patients. We know that many of our patients with COPD have consistent multiple morbidities in terms of their conditions, put them at elevated risk. They also typically are either current smokers or former smokers that would also elevate the risk. And most of those patients are older adults as well. So those patients really increases their overall risk of having severe outcomes from these. And these are ones that we really want to be a key focus on in terms of our protection strategies.
And also our management of the chronic disease is helpful, right? Like now with COPD, we have triple therapies that can actually reduce mortality. For diabetes, if we manage their diabetes better, people without complications of diabetes don't seem to end up in hospital. So when they looked at the US database, if you have diabetes with complications, you were one of the top 3 people most likely to end up in hospital with COVID. Yet if you had diabetes without complications, you were way down on the list. So our management of the chronic disease itself would be very helpful as well.
Yeah, I think that's such a great point with those patients as well, too, Peter, is that these are patients that qualify for treatment if they end up getting COVID-19. And we were just looking at some of the Ontario data of using drugs such as like Paxlovid for those patients, really pretty low use for some of our really sick patients in comparison to what we see. So it's really an opportunity that these patients get sick, high risk of ending up in hospital, that we could use treatment options that are covered within these education modules as well.
Yeah, and I was actually looking at some of the drug interaction. I remember when it first came out, they said, "Oh, it blocks the cytochrome, and so therefore lots of drug interaction." And when I looked at the table, on the table of drug interactions, they included drugs that don't have interaction in green boxes. So on that list, there are drugs that do not interact. So when I take out all the drugs that don't interact or minimal interaction, or the net result is that you continue to use the antiviral therapy, the list of people that you cannot use it in is actually quite short. So what I want you to do is, let's work with pharmacy and things like that to make sure that we manage those drug interactions. But definitely we need to make people aware that they qualify. And we'll talk a little bit about how we want to prepare patients, in case they were to get COVID. Here we have some more questions, right, Mike? There was lots of questions coming in about long COVID. When will this brain fog go away? What is causing this brain fog? When will I feel normal again? And will people be recovering from long COVID? So the majority of people over a year, when they look at the data, do get better. But that's a long time to wait in terms of getting better. Long COVID, any medications that help. And you're going to see lots of weird stuff on the internet saying, try this, try this, try this. But we have systematic studies being set up right now where they're looking at the different types of strategy. One of them is the antivirals. Another one is anticoagulation therapy. So there are many studies that are ongoing. And then how to sort of slowly push yourself to regain. So this increase in activity, the concept of pushing your mitochondria. So the virus basically flips your mitochondria so that it doesn't burn both types of fuel. So normally we burn glucose, which is quick energy, and that does not require oxygen. But then to burn fat for long-term energy, we require oxygen. So it turns out the virus flips you over into burning quick energy. And it's a smart move for the virus because it doesn't need oxygen. So just in case it wipes out your lungs, it doesn't matter. It can still produce energy to make the virus itself. So therefore, the virus does that flipping. And if it doesn't flip back, then we're in trouble because now you're burning quick energy. So that's why you'll hear people saying, I can only go for 2 minutes and then I just collapse because you're not switching over the energy. And by the way, this isn't something new. Cancer cells do this phenomenon as well. They flip over and they burn mainly glucose because it does not require oxygen. And in cancer cells or lumps, there might not be very good oxygen. So in other words, we can see what the virus is doing and try and figure some of these concepts out. And these are the things that might lead to new therapies and things like that. But at least it gives people some understanding as to why they're feeling tired and why their brain seems like it's running a little slower because their power plants are not burning the right kind of fuel.
Yeah, and one of the key things that came up just within the last bit, it was a new meta-analysis that looked at actually vaccines for prevention, and it pretty consistent across the board. Because one of the questions that have come in tonight is, did we see more long COVID in terms of the basis when we pre-vaccine? And that's the case. We saw a larger amount, but at the time when the alpha wave came through, we really weren't sure what long COVID was. A lot of people got sick and never really recovered, and then it started to lead to that. But there was a portion of patients that ended up, usually healthcare professionals, that were infected during the alpha wave that still have symptoms today, 2 years, 3 years later. So it's still possible that's there, but we know that immunizations seem to reduce that risk based on observational data. But one of the interesting things they looked at is about 60% of the trials found that patients that had long COVID symptoms, if we gave them another vaccine, be it an mRNA vaccine or being something like the Novavax vaccine, symptoms seem to improve in some of those patients as well. So it may be one of the options that they're considering later on, but lots of stuff going on in the space because there's so many people that are infected with it as well.
And similarly, those that got antiviral therapy, because we were able to stop the virus from invading multiple tissues, those people seem to do better as well in terms of the long COVID symptoms. So the goal is really to contain the virus, right? But not let it go into different tissues. And we're learning that COVID virus is basically, or the SARS-CoV virus properly to name it, it enters through your lungs, but then it can go to many different tissues. So wherever there's an ACE2 receptor, it could potentially get into that particular space. And that's why we're seeing these complications. And perhaps one of the theories about long COVID is that these viruses are now hiding in different places and replicating, just like, how we have shingles, that's basically your chickenpox virus hiding in the ganglia. And so therefore it can reactivate in those kinds of things. So people are studying this thing, but I think the concept to get across is that this virus may use your window to get in, the lungs to get in, but then it can go into multiple areas. So therefore, if we can block it off, so whether that's because vaccination, you've got antibodies that can contain it so that it can't wander all over your house, or if you're taking an antiviral, so therefore you stop the replication. So again, it's not allowed to wander throughout your house. Those are two good strategies in terms of avoiding long COVID. But of course, the most important strategy is not to get the virus in the first place, right? So that's the best.
The frustrations are very, very similar to what we expect. No definitive answers. And I think that with COVID, it's been really, everything has been non-definitive answers for almost anything since the start of the pandemic. The fatigue, the dyspnea, the tiredness, common, limited activity tolerance for a lot of these patients. And I think that Peter described it well. Well, I've heard others describe it as, imagine leaving your house with your cell phone battery at 11% and that you have to make that last a whole day. That's consistent. And that's one of the challenges that many of these people have to go through. So unlike most conditions where we push patients to be active, it's really about pacing and making sure that they have enough energy to last throughout the day. Non-linear evolution of the condition and that lingering cough. Biggest frustrations here. Sorry, going one more time. And this is biggest frustration when treating patients with long COVID, Peter. It's a lack of resources, information to help these patients that are non-vaccinated, and especially now it's, well, I've already had COVID. I have these symptoms. Why bother at this point? Not being diagnosed with, or lack of organization committee to provide services for these clients, lack of agreement on what long COVID really is. One thing that we've seen is patients really don't like when you use the word post-acute COVID syndrome. The reason why, as I said, for me, it was never post-acute. It's been ongoing since the start of this thing. It's long COVID, long haulers, many of those terminologies. And the lack of what we can end up doing for our patients is really trying to work with them to target and making sure that they live the best possible life that they can and hoping that things will improve. And as Peter mentioned, most of the data is showing the longer you go, patients will recover, continue to recover. The average recovery was typically 9 months for a lot of these individuals that ended up having past 6 months. But some patients seem to persist for a long period after that point.
And also, this is kind of like heart failure, like when you ask a patient with heart failure, how you doing? They go, not bad. And that's because as their heart function went down, their activity levels went down. So if you ask them, can you go upstairs? No, I can't go upstairs, right? So they're doing fine because they basically reduced everything. So that's what I found with some of these long COVID patients. They'll say they're doing fine, but if you ask them, okay, compared to before COVID, oh, no, I'm nowhere near that. So in other words, they're fine in the sense that, okay, I'm able to get up, I'm able to go and do at least some basic things, but they're not back to normal. And so that's our biggest concern is we're now collecting a fairly large crowd that may just be not complacent, but they realize that they can't get much better than this. So therefore they accept this as being normal. And that's the sad state of affairs because I still get frustrated. This virus only makes 29 proteins. It only has, the blueprints for 29 proteins. 4 of them are structural. and 25, I can't tell you what they do, but those 25 proteins are what we need to figure out, like what are they touching inside the body that can cause this thing to go on for such a long period of time. And I'm hoping that the smart people that are doing the research are collecting that information. They are doing lots of stuff. They're testing where they're giving antivirals during long COVID can wipe out some of the viral replication if there is some stuff like that. So there are ongoing studies, but for patients, it is very difficult that they got to go through this. Now, Mike, you love these bubble graphs, so take us through this bubble graph.
So living well with beyond COVID-19. So both Peter and I worked with a great group of colleagues to put these together. They're educational series that are designed to help healthcare professionals educate their patients about COVID-19. So who's it target for? Really, what we wanted to do is really to provide you a tool to make things simpler, to have those discussions. We know how challenging it is within clinical practice now to have these on a regular basis. So what kind of resources that you can provide to patients? They can be accessed, and we'll show you the link a couple of times at chroniclungdiseases.com. The PDFs are free of charge, lots of hyperlinks within them. And the three main modules that we've created with them are prevention strategies for COVID-19. We're going to be focused on vaccination for these patients and public health strategies, treatment options that we have for COVID for patients. So these are the Paxlovid of the world, the remdesivirs of the world that we have, as well as long COVID rehabilitation and management as well. The clientele that we have for these are mixed. So it's patients that you see, as respiratory therapists and other clinicians that are joining us tonight as at a high risk of complications for long COVID-19. Some of the patients who are suffering from long COVID, you'd be surprised if you just start asking patients if they've had COVID-19, if they still have symptoms, how many of them are still having some lingering cough, persistence, the tiredness, the fatigue, the dyspnea that we see, especially in some of those respiratory patients that you see on a regular basis. We design these really for any healthcare professional, those nurses, the respiratory therapists, physician specialists, pharmacists, anyone who touches a patient that could have COVID-19. And it really doesn't, Living Well series doesn't discuss treatment options for people who are hospitalized. We didn't really want to go to the level. We wanted to not really focus on, if you're going to the hospital, the last thing I want them to do is to go to the clinician and say, I read in this book that you need to take this, I need to take this therapy. What this was designed is to really empower these individuals and engage these individuals to be involved, to have a more active role in terms of prevention and treatment of their COVID-19.
I think that's a good point, Mike. I mean, and the first part of that is the information, right? In other words, providing patients with good information that they can rely on. Because unfortunately, the internet has been good and bad, right? We can find all sorts of weird stuff. And they were saying that these chat GPTs, this artificial intelligence, they can only collect data from what they see on the internet. And sometimes they collect weird data, and so therefore it comes back with very, very strange results. It was very funny. They had a thing on the American television network. It was a lady who's a psychotherapist, and just for fun, she heard about this chat GPT, like for building a perfect mate. So then she just wanted to try it out, and so she punched in all her likes and dislikes and everything else, and up pops this, chatting, sort of boyfriend, I guess, that she had. And she was great. You text and then the thing checks back, and it was very attentive. And then on day 7 or so, it got weird. So this thing, apparently the way it got weird was this thing apologized for cheating on her and was groveling and stuff like that. And then she said it got weirder and weirder thereafter. So I'm assuming that ChatGPT had looked at a lot of conversations between people, and it seems like there's a lot of sort of cheating and sort of apologizing. And so therefore it incorporated that into this reality. So therefore, I think we have to be careful, as we're looking for information. And I think this is why providing good information, as Mike was talking about, is so important. What about this stuff? Philosophy, self-management, behavioral stuff. Mike, you want to take us through this?
So this is really, it's just what I like about all the stuff that we try to design, and a lot of the stuff that Respiplus does is really focusing on self-empowerment. We as clinicians, we can't handhold our patients through all of these conditions on a consistent basis. So what can we do to empower them to be that key arbiter of their own health? And my concern with this is that if we're looking at things such as vaccines, we can hit our patients constantly and consistently, which is what we should be doing. But things such as treatment options, where you only have a 5-day window to end up looking at those individual treatment options, unless that patient is empowered, unless that patient knows what to do and what to do with it, and if they develop these symptoms, then we're in a potential issue. And that's really what we target a lot of the design of these. And it's consistent with a lot of the materials that Respiplus has done before. It's really giving them self-management skills, which is crucial for patients with respiratory disorders, as well as many other conditions. We had Alan Kaplan work with us. And if you know Dr. Alan Kaplan, We really wanted to focus on an action plan as crucial as respiratory therapists, as you guys know, for our patients with respiratory conditions. We've also incorporated that for COVID-19 as well, and looking at some of the barriers and personal biases preventing and treating COVID-19. So the first one that came up, so go ahead. Sorry,
go ahead. Well,
so
I was just going to say, this is the first module, right? So the modules are actually in a PDF format. So basically you'll be able, the patients can download them and things like that. So the first module is about, as Mike talked about, prevention strategy. And so this is where we can talk about what are the ways that this virus transmits? How can we protect yourself? How can we prevent? And so therefore vaccination, masking, when should you mask, those kinds of things are all here. So this will be the collection of things. Now, the ones that did make it in are the crazy things that I talk about, how do you take a photo with your family, like this group family photo. So I tell people, stand up there, take off your mask and then just hold your breath. Okay. So smile beautifully while you don't suck in, and then just put your mask back on. So therefore we can have high-risk people taking a photo without exposing themselves to a lot of strangers, especially if people are coming from all over different parts of the world. You might want to have a nice photo without a mask, but everybody's freaked out, so just hold your breath. So these are simple things that we could teach people, that the virus cannot enter your body unless you inhale it. Okay, so in other words, if you blew straight on my face, if I didn't inhale, the virus can't really get into my respiratory circulation. So these are things that can now help empower patients. I remember this little grandmother said, I just want to hug my grandkids. It's been 3 years. And she was petrified, because the kids were at school and they were picking up stuff. So I said, well, why don't you just hold your breath? And what do you mean? So when little Johnny comes running, just don't suck in when he's around you, and that way you can't bring in the virus. And so when little Johnny's head is over here, you can breathe all you want. And then when he pulls away, just hold your breath. And that seemed to give people a sense that this virus is not taken over my life. And there are things that I can do in addition to vaccinations and those kinds of things on a daily basis that will keep the likelihood of me getting this virus lower. And I think those things are very helpful for people as we go through some of these documents.
Yeah, and I think it's really important, Peter. And I think that the issue is we are going to have to start meeting our patients where they're at. We know you come out and you go to any event, there's nobody that's wearing a mask on a consistent basis. So it's what is the components that we can end up doing, meeting our patients where they're at. What are those high-risk situations, looking at it and translating them to their risk categories. So if they have COPD, if they're older, they're a smoker, we know they're at elevated risk. If they haven't received all their boosters, what can we do to end up helping to protect that individual across the bases? And I think that's going to be the new norm moving forward. I'm hoping, because we haven't seen a new variant, we've seen a lot of Omicron variants that have happened over this period of time, that we may get lucky during the summer, similar to what we saw during the Delta wave. We will have low numbers again, through natural infection plus immunization, that we may have a really good summer with high humidity, which doesn't bode as well for virus transmission as what we've seen in the past. So we'll see, but we may change again in the fall. So it's really important about keeping your patients informed, and that the strategy will continue to evolve. I think one of the key issues that we've seen from our prevention strategy is that you told me that I would need 3 of these, or I'd only need 2 shots and I'd be done. And what do you know about this? And it's a key thing of letting them know that as this continues to evolve, the longer that we live with this virus that we hadn't seen until late 2019, early 2020, as we learn more information, we can look at more effective ways of actually protecting ourselves and protecting them from ending up in hospital.
And also, Mike, I think we need to sort of roll back some of as soon as you leave the house, you have to have a mask on. Because I remember in like Qatar, for example, they said, as soon as you leave the house, you have to have a mask on. So it means that if you're walking by yourself on the road, you had to have a mask on sitting there. So I think on the one hand, we want to teach people the high-risk situations where, let's say, for example, a mask would be useful. On the other hand, we need to teach them that in these situations, you don't really need it because there's nobody around you. So oftentimes I'll tell people somebody has to bring you the virus, like a human being. So therefore, if there's no human beings around you, you're driving by yourself in a car. And I've seen that, people driving in a car and they got a mask on. So they don't need to do that. So I think that's sort of carving away the areas where we don't have to wash every package that you bring into the house, like we did before. I had my relatives washing carrots, stuff like I said, that's inside the package even. So in other words, getting rid of that baggage and then just keeping the critical areas would be very useful. Then people will say, you know what, it's only in these critical areas that I have to think about this public health stuff, in which case that's more doable as opposed to the, lockdown style that we had before. That would be helpful as well. And then, of course, sort of appropriate use of vaccination. So instead of just saying, just keep getting shots no matter what, sort of appropriate appropriately using it. There was one point where people wanted to get shots every 2 months or something like that. So I think now we're learning. So does it wane? When are you at risk? And I think that's very helpful to sort of put it into proper perspective in terms of all the processes that we can do to keep ourselves and our loved ones safe.
Yeah, I love it. And I think that's a terminology of that, if we can give our patients spidey sense so that this situation looks to be higher risk, maybe I should do something about it versus saying, I'm giving up on everything. I'm just going to go and live my life. So it's that component with that in between. But the next module that we developed was really looking at treatment options, was really focusing if the patients were to become ill, is how do you, who is at high risk? One of the things that we've seen and is consistent really in the literature as well is that some of the patients who are at 40 to 50 group think, what, it's no big deal. I'm pretty healthy. I fall within that group as well. And, some of these patients are starting to develop comorbidities. So you could have a patient who has, diabetes, as Peter's mentioned, somebody with consistent cardiovascular risk factors as well. They're at elevated risk and they may not even realize their risk. And we know from the data that we saw in the US, significantly higher risk of dying in hospitalization in comparison to someone 18 to 29 years of age. So it's really telling them they're at high risk. And you'll even see this with a COPD patient who's coughing, his shortness of breath, on triple therapy, had exacerbations, and don't really feel that that's really the old people that are at really high risk. I'm not that bad. Or I know a friend that got it and it wasn't too bad. So it's just letting them know it's how to recognize the symptoms of what COVID-19, what tests can be done, and really being prepared to deal with it. That action plan, which we're going to talk about in a bit, that Dr. Kaplan was involved with, and then some of the prescribed treatment plans. And I've been talking to clinicians a lot about Paxlovid and outpatient treatment options, and they're vastly underutilized. And one of the key things that we've seen is that patients don't realize in time, don't realize that they're at elevated risk, that, oh, it's not too bad, it's a bit of a cough, and then as things start to progress, it's too late. We don't have those options that we have for those individuals. And that's why that 5-day window is really crucial, especially for those high-risk patients.
Yeah, and I don't think we did a good job changing the narrative, because the first narrative was that there was no treatment, right? And it was either you lie at home and suffer, or if you're really bad, you end up in hospital on a ventilator. Those were the two extremes that would happen. And we didn't have an option in the middle. And unfortunately, I don't think we created a good narrative because there was a shortage of supply. So therefore, we didn't want to tell a whole lot of people. So we said the highest risk people. And so therefore, I think the perception that people had was your chemotherapeutic, immunocompromised, only has 3 white cells left in their body. That's the patient that would qualify for these types of therapies. And yet the narrative from the government has changed quite a bit. They're saying, look, if you're over 60, if you haven't had all your vaccination, so they've expanded that group that says, if we treat these people out in the community, then they don't end up in hospital. Now, the other problem is that the outcomes of these studies will determine whether it's a positive or negative study, right? So if we look for death rates, then you go after the highest risk people and you'll see a death benefit perhaps, or a hospitalization benefit. But for people that are less likely to die or less likely to end up hospital, they still feel better on the treatments. It's just the outcome of hospitalization may not be realized. So that's why I was reading these, reports saying, people younger than this age, there's no benefit. No. It's just we set the bar as being hospitalization as being the outcome, right? So if we look at that outcome, then maybe those people won't have it. But if you talk to them, they go, well, the fever came down within a day and I felt better, and therefore the recovery is better. So therefore, for people that may be younger, but nonetheless have lots of these organs, as Mike said, brain issues, heart issues, lung issues, liver issues, any major organ issues, then we should just think about it, because those are the exact patients that maybe we can stop the virus from wandering around in the body. So the way I look at it is that we want to make sure that people don't die, number one. We want to make sure they don't end up in hospital. And we also don't want the virus to wander around in their body, because then the risk of long COVID is much higher if we allow the virus to sort of just take a cruise inside your body.
Yeah, it's a great point, Peter. And really the data that came out from the CDC worldwide, it's I think it's 80% of the deaths that have occurred with COVID-19 have been 60 and above. So that's really the criteria. I know there are people that are connecting from across the country. So we're Peter and I are in Ontario. We call it the center of the universe. So for us, it's 60 years of age and above. Is everybody would qualify for this. So just letting those patients know as we age, majority of the deaths are occurring 60, 70, and 80. Each decade increases the overall risk of hospitalizations and mortality. So those are the patients that we really should be focused on, especially if they have these comorbid conditions as well. So we really go through this whole thing within this treatment options for these patients so that they're aware of it. So Many of you treat patients with respiratory conditions, so what you can do about this. I know that because there's a lot of respiratory therapists on tonight is asthma. Most of the time, if it's well-controlled asthma that we've talked about with Peter was mentioning with diabetes, asthma generally, if the patient is well-controlled, their risk of severe COVID-19 is very, very similar to most of the groups that we see. So not overly increase of risk in comparison to patients, for example, with ILD or with COPD. And then long COVID, last one is looking at rehabilitation and management, and then really defining what that is, the importance of rehabilitation, strategies to deal with cough and fatigue, importance of healthy habits. And it's really trying to go back to the basics as we don't have a lot of options for those patients, the mental health and recovery, and then resources and support groups that can be there. The good news is that, David, so Peter and I work with David Strain, who's the internal medicine specialist within the UK. He does a lot of work with chronic fatigue syndrome or ME, and they think that there's going to be a breakthrough that's going to help for both ME patients and as well as long COVID. There's so much research that's being involved here, so we're hoping that we'll actually have more strategies that will come out. But again, not downplaying what these symptoms are for our patients and really providing them support here as well.
And I know, Mike, every time there's a presentation, they always start off with long COVID has 200,000 symptoms, right? And then you're sitting there going, how do we manage these? So what we try to do is try to group them. So are these mainly sort of immunological? So in other words, the body is attacking itself. Is it that kind of bucket? Or is it a GI bucket, where they have a lot of diarrhea, bloating, that kind of thing? In which case that would be a microbiome kind of story. Or is it the lack of energy, for example? And then we're thinking about the mitochondria story. And is it a CNS thing where there's a lot of involvement of brain cells? So this virus really likes the brain cells. So you know how when it wipes out your smell, those are the wires that are coming from your brain, your olfactory nerves that get wiped out. And the virus can actually quickly go into the brain area. And that's why we're seeing increase in dementia, Parkinson's, also depression, anxiety. All of those things are increased as well. And so basically we can sort of collect symptoms together. And then once we collect symptoms together, then we can use our existing medications to try and treat it. So if it's sort of a depression thing, then we use antidepressants and things like that. If there's tachycardia because your autonomic nervous system has been affected by the virus, then we can use beta blockers to slow it down. So in other words, we try to collect the symptoms together and then use our current therapies that we have approved for those things to try and treat it in the interim. So as smart people like David Strain and Angela Chung here in Canada are doing these studies on long COVID, testing these different strategies, eventually we'll have some algorithms that says, if you have these kind of symptoms, these are the things that you should try. If you have these kind of symptoms, these are the things you can try. But until those studies are done, we should just start collecting patients in this fashion so that we'll have some sort of rational way of approaching these 200 symptoms that patients might have.
And it's really hard because you hear patients that will be reading in support groups online and they'll say, this person did this and all of their symptoms disappeared. It's been cured for that. That's what I want. And anecdotal is anecdotal. So it would be great if we found that miracle treatment that we have for everybody, but I think it's going to take a little bit of time. The things within this module will really end up helping to give them a little bit of support. The key thing here is to recognize that they have this condition and recognize the impact that it ends up having and be supportive of that basis. I think that was the key issue that we saw with ME and CFS, that a lot of these patients felt like they never really got any support from clinicians or healthcare professionals or even family members for that as well. Action plan. So lots of things that we put together. This was Alan Kaplan was really a key component with it, but really looking at an action plan. We'll go through the individual steps. It's really to help them step through to act quickly if they develop symptoms of it. Green, orange, red, really trying to make it as clear as possible. Again, another tool that's available that can be downloaded, and we'll look at this in each of the sections. But really with the series, it came up with some things such as checklists to help to identify patients at serious risk. So really letting them to know, to empower them to be involved in terms of their COVID-19 protection strategies and treatment strategies if required. Self-assessment questions to test their knowledges regarding the prevention treatment of long COVID. And then confidence questions to identify areas where the patient may need more education to feel confident in self-management of their condition, their infection, and long COVID. The action plan, which I showed you, and as well as a whole bunch of appendices that we try to include. So the team with Respiplus, what they ended up doing is actually providing a summary for both healthcare professionals and patients on those individual treatment options. So quick reference, so if you're looking for that, it's one-stop place that you can go and grab that information as well. So I'll finish this one, and Peter, it's Living Well with Beyond COVID is really an education program by which patients can gain knowledge, develop confidence, apply to making decisions, to recognize and treat infections, as we talked about empowerment, confidence, and really helping to demystify COVID-19. But as for clinicians or healthcare professionals, one of the key things that we can see is that this is actually the goal here is to provide a resource that can simplify these conversations so you can do them relatively quickly, give them something that is going to have the information they require to save the time to make sure your patients are protected from COVID-19. So let's talk about how do you use it.
So let's say it's a patient, right? I'll go over here for a few slides. So let's say she's 59, she just comes in for a refill. She's diagnosed with COPD 4 years ago, and she has high blood pressure for the last 10 years, managed well on medication. And she's really she doesn't care about COVID-19. So these days, most of our patients don't even mention it. And she says that she was vaccinated a year ago with her primary series, hasn't had any boosters since then. So it's been over a year. And you're a little concerned about her. And I would even say that as physicians and healthcare providers, pharmacists, and things like that, COVID has fallen down off of the main list of things, although it's still the number one causing, death and disability still, but it's fallen off the list. So the question is, when you see a patient like this, should we be approaching, her COVID risk, for example? She's just here to renew her prescription. The easy thing to do is just say, here's your prescription, get out. But perhaps we can spend a few seconds on this. So next slide, please. So what do you think? So if you saw somebody, she's relatively healthy, she's not in trouble, she's not having a COPD exacerbation, she's in good shape. Is that the time that we should approach them? Or is it the time when they call you and said, I'm feverish, I'm body achy, and stuff like that? So obviously a preventative strategy might be better. So if we were to approach her now, then we can get things in place, and that way it might be a better strategy. So next slide.
Yeah, and one of the key things here too, Peter, it's looking at a presumptive ask is a key thing from our basis, is just saying, oh, I love, this is Vivian Brown, so Dr. Vivian Brown, her recommendation is, she goes, oh, I see you have COPD and you haven't had a booster for a while. Which arm would you like to receive it in, your left arm or your right arm? And the vast majority of our patients say, yeah, so I'll get it in my left arm. And it's not really even much of an overall conversation. It's a great and easy way to actually protect these patients.
Yeah, and so if you look at her, right, like her vaccine status is over a year ago, so her antibodies will have waned. She has she had COPD, or has she had COVID-19? In other words, a lot of people are not telling us that. So they might have had it, they might have swabbed themselves or something like that, or their kids got it. And so they presume that they've had it. So if they've had COVID-19, it actually changes their risk profile. So based on the US Veterans Database, the people that had COVID were at increased risk of every cardiovascular event. So heart attack, stroke, arrhythmias, and blood clots. And if you have more than one COVID infection, the people with 3 or more were at significantly higher. We're talking about 300 or 400% higher risk. So we're talking a very large increase. And to Mike's point, if you were in hospital, then even with one infection, your risk is now 300% higher than normal people. If you're in the intensive care unit, it's closer to 600% higher for those bad things. So that's why keeping track of the COVID infections is useful, both in terms of number and also severity. And then if she's on any medication, did she need prednisone, which would then immunocompromise her? Is there any COVID-19 misinformation? And that one we don't have to check. You kind of know your patients as to which one are getting the right information, which one are not. But then having these little modules is helpful because you know that the information is trusted. And so therefore, if you pass that information on to them, that'd be useful. And then assessing the exposure risk. So let's say they live as a hermit and they live by themselves. There's no kids, there's no exposure. They don't go anywhere. They have their groceries delivered by Grocery Gateway or something like that. So therefore, they never see anybody. Then their risk is quite low. But if let's say they're working at a daycare and they're constantly exposed to kids, then the risk of exposure is very high. In which case it would be important for us to, approach this subject with them. So we're going through this little thinking cycle, and then we just need to pass that information on to our patients as well.
Yeah, and then one of the key things too is with COVID-19 that we hear all the time is that I had a breakthrough case. I'm now protected forever, and everything is going to be fine. I don't need to have to worry about this anymore because I had it and I recovered. As Peter mentioned, the more infections you have, the observational data shows that it may be an increased risk of complications for those individuals. But we do know that if you have hybrid strategy, vaccination plus COVID-19, what will end up happening is that it'll actually lead to better protection for those individual patients. And after a COVID-19 infection, you're likely have at least 6 months of protection before you're going to be at elevated risk, similar to what we see with a vaccine as well. So some of the things in terms of who's at high risk, again, a tool for patients, and it looked at the risk factors. One of the key things, it's most of you are familiar with it. Questions that I always get are, what about prednisone? What about steroids? So is prednisone dosing that we see that puts a patient at elevated risk is 20 milligrams or higher per day for at least 14 days. The one group that I really want to call out here that really doesn't get protected is pregnancy. We see this with influenza. We see this with COVID-19. These patients are very high risk of actually complications for mom and for baby. So if you have a patient that is starting on folic acid, or you know a loved one or a friend who is trying to get pregnant, you want to make sure they're up to date with their COVID-19 strategy, because these are patients that are elevated risk. Anything here, Peter, that you see that you want to highlight from in terms of the overall group?
Yeah, I think when we talked about high risk people, I think all of our heads defaulted to the, prednisone, immunotherapy, cancer patients, right? And then I think about my practice, I go, yeah, I have about this many of those people, right? But when I look at over 60, like that's a huge part of my practice they're high risk. So if they get it, they need treatments or consideration for treatments. If they are not fully vaccinated, they need to be fully vaccinated. So in other words, just over 60 is a large group. And then number 3, chronic medical conditions, as you pointed out, any major organ, so heart, kidney, lungs, any of those things, that's actually the bulk of our patients right there. And then if you look at obesity, right, like living with obesity, that puts you at high risk. So actually some of the ones that we don't think about as immunocompromised patients are actually the most common people that we have. And so if you look at this, it's pretty much 90% of your patients, other than the 20-year-old that's perfectly healthy, no diseases, then maybe that one I don't have to talk to them today about COVID-19, but pretty much everybody else that you're looking after, it just should cross your mind, because whether you're talking about diabetes, COPD, asthma, liver disease, hypertension, anything, COVID-19 is the highest chance of killing somebody in that category. So higher than a heart attack, because heart attacks don't happen as often as COVID-19. So that's why that's the highest risk. So let's just deal with that high risk first. And then we can go and deal with all of the other things like blood pressure and lipids and all those things. But in terms of the thing that will cause the most harm immediately would be actually COVID-19 right now. And so therefore, let's just put that at the top again. And like I said, it applies to many of our patients. So just have it go through your head in terms of thinking, and then that way we can bring it up with a patient.
It's such a great point, Peter. And I just want to call it out here as well. It's one of the confusions are looking at risk factors for other conditions as well. Anyone that's on this list, if you see yes to this, they're also at higher risk of influenza. So they make sure that they get their annual flu shot on a consistent basis, and also a higher risk of pneumococcal disease for many of these patients as well. So anyone with a chronic condition, generally and over the age of 60, should be considered also for pneumococcal vaccines as well. So what's nice about it, it's one list for everybody. So if you look at it, well, Mr. Smith, you came in for COVID, I see you're at elevated risk, but let's get your flu shot in, let's get you protected from pneumococcal disease as well. So based on your evaluation, she is at high risk. She has COPD and high blood pressure, would put her at a higher risk of developing COVID-19. She says, are booster shots really needed? How often will she need a booster? And I think it's $1 million question. So the new recommendations actually came out from NACI, not fully adopted, and it will be different within Quebec and many of the other provinces as well. But what they're looking for a spring strategy is anybody who is 60 years of age or 70 years of age or older, 80, long-term care, what they're going to focus on for that spring booster basis. But what we do know is that only about 1 in 3 to 1 in 4 Canadians over the age of 18 have actually received any type of booster within the last 6 months. So almost all of your patients are probably due for a booster that you'll see. So it's worth asking about it, not assuming that they've actually received it, and to make that recommendation from that as well. In terms of if she gets COVID-19, she can take a prescribed treatment to keep her out of the hospital. One of the things that we see here for, again, a lot of respiratory people that are on, salmeterol is one of the drugs that interact with Paxlovid, which may seem kind of odd, but we have other choices that we could use. Tools such as University of Liverpool's drug interaction tool for COVID-19 is an excellent tool, as well as I work with the Pharmacy 5 and 5 leads, so which is Kelly Grinrod and her team at the University of Waterloo. They have an excellent drug interaction table that can be used with some recommendations. But generally, for a lot of these drugs, we just stop them for the time that they're on it and then restart them afterwards, or things like as Norvasc or any of these blood pressure, cut the dose in half. take them, wait till they finish their Paxlovid, and then 2 days afterwards, bring them back to regular doses. Lots of different things. It's just being comfortable with those treatments and engaging that patient so she knows what to do if she becomes sick. Peter, anything to add from your perspective?
Yeah, I would just put about the drug interaction thing is I explained to patients there is two parts of the drug. So the first drug blocks the pair of scissors that cuts up the pieces that make the virus. So therefore, that's the real drug that's doing the job. By blocking the scissors, the parts don't get cut up, the virus does not get made. The problem with that drug is that it only lasts for a couple of hours in your body. So therefore, we would have to give it to you as an intravenous drug. And now that means going to hospital and all that kind of stuff. So to get around that, the scientist says, okay, so can we keep the drug in your body longer? So they give ritonavir to block off the cytochromes. This is where the drug leaves your body. So if we block that off, then we can keep the drug in your body so that now I can give it to you as a pill form and you can take it at the comfort of your own home and we don't overload the hospital system. So I think explaining the rationale of why they combined the two so that we keep you out of hospital, we don't overburden the hospital, and that's why we have this combination of the drug. But because of that, by blocking that, then we also block the elimination of other drugs that you might be taking, like your blood pressure pills and those kinds of things. And so therefore the drug, if they can't leave, you're going to have more of it. So that's why we might hold it or cut the dose and those kinds of things. So I think when we explain it in that fashion, that it was really designed so that we can keep you at home and we don't overload the hospital system. Most people go, that's pretty smart use of science, I guess. And then if we just have to play with your medications for 5 days, people don't seem to be upset with that. Whereas if you tell them there's lots of drug interaction, it almost makes it sound like, why did you guys build such a horrible drug? Yeah. But it was so that people can take care of this horrifying disease at home, especially during a time when the hospitals were like basically overloaded and we didn't have space to go and have people hooked up in the intravenous. For those that really have drugs that they cannot change and that have a horrible drug interaction like amiodarone, which hangs around for a long time in your body, then for those people, then we have remdesivir, which doesn't seem to interact. But the problem with that is that it's an infusion. So it's an IV for 3 days in a row. So therefore, you have to go to a hospital or a healthcare facility to get that. But we do have options for those that where the drugs, we just can't adjust them. And there's only a few drugs like that. Then we have other options for them as well.
That's great. So the case study is, how do you start the education process? What tools are available? We talked about the tools in terms of the series that we have. We want to explore the patient belief, concerns, COVID-19 misinformation. Does she have any questions? Don't plant more information. The key thing here is to really ask open-ended questions to see what she's doing to protect herself. What are her thoughts about COVID-19? And then ask if you can actually share that information. What we want to do is for patients that are elevated risk, if they can, try to, if it's, again, for the RTs that are on, pharmacists that are on, work with the patient to get their kidney function. So this would be relevant for if they were to be using Paxlovid. It's one of the barriers that we've seen for clinicians to actually prescribe it. If you don't know the kidney function or hasn't been done recently, that could be a barrier for these patients. And then patients' continued actions at home. You know what? The modules are there for their own interests. How they do the prevention and treatment options, and has to highlight any of those questions. The action plan that we have, it's really a contact list that we basis for this one. Green on what they can end up doing. So this is about kidney function, about their symptoms, what to do if they end up getting sick. So similar to an action or COPD action plan, asthma or a COPD action plan. What to do if they go orange, you know what, they have the symptoms, how to manage those ones. So again, providing the patients a step so they feel empowered to make those choices of what they can do for those symptoms, as well as if they're actually having severe symptoms and when they should go in. We should be reminding patients that, you know what, Paxlovid and outpatient therapies are really for patients that in an orange phase. If they're having severe difficulty in breathing, severe chest pain, confused, they should be not looking to go on those products. We should be sending into the hospital right away.
Yeah, and I think, Mike, that orange section is where that's the new information. Like there's something we can do as opposed to just lie there until you become the red section and then you have to go to hospital. And I think what you talked about with the EGFR. So instead of expecting a pharmacist to log into some laboratory kind of website, if we just provided the EGFR ahead of time, like a photocopy it or something like that, that'll have the date and the number. Because Paxlovid, for example, needs an adjustment if your EGFR is below 60. And so for the pharmacists that in some provinces that can prescribe and fill, then they would have all the information they need, the drugs that the patient is on, and also the EGFR to make any adjustments. And that just makes it so much easier for everybody. as opposed to on the weekend, patient goes to the pharmacist, we can't get a hold of the EGFR, and then we don't know what dosing to give. So that just makes
Exactly.
it smoother. Yeah.
And we have 5 days, right? That's the issue, right?
Yeah.
We need the treatment. We need the treatment as early as possible because the virus only grows in that first 5 days, and then it's the inflammation that leads to all the issues. We want to prevent the inflammation by controlling the virus. So that 5 days is so crucial. So if you can,
And we don't want the virus to do a tour, no cruising around inside the body.
Exactly. As we mentioned right off the beginning, and we'll provide this the list, but it's really looking at chronic disease, lung diseases. These all are available through chroniclungdiseases.com resources, English, COVID-19, all available for everyone. And I'm just going to put here, I think I can put this, no, I think Maria will have to put it in the chat if that link in so that you'll be able to access it as well. All freely available. Respiplus is going to continue to update this information as well. So there'll be new tools, new information that will be accessible for you as well. So to finish, we're going to try to empower our patients. And this is something that has been a focus of respiratory medicine for a long period of time, really at how they can prevent serious outcomes of COVID-19 infection. Really, treatment options are available for some of the high-risk clientele basis. So really the older patients, the patients that are sick on a consistent basis or have multiple chronic disease states. They need to be able to action on this one. So that action plan can be there and can be used as a tool for education. Talking about the long COVID and the symptoms that can occur with that one, and really more comfort and less uncertainty in terms of the information that we're providing. And we really wanted to make this a one-stop shop for all these patients so they can have good, clear, concise information that they use to actually increase their overall knowledge. And I think this is the last one, Peter.
Yeah, no, this is great. And we want to thank everybody for staying with us and hanging out there. I'm hoping that you learned something useful, that you have a good resource, and so therefore the resource you can peruse at your leisure as well. And then when you're comfortable with it, just identify some patients, that says, you can tell them, here's how you can learn about prevention, here's how you can learn about treatments, and then long COVID patients. So you'll have many people that you're looking after or that you know personally, where they can do with some good, useful information, some accurate information. And so that's what these modules were designed for. So we want to thank, the folks that helped us put this together, Respiplus, of course, in sort of spearheading this project, along with the sponsors, AstraZeneca, GSK, Moderna, and Pfizer, for their sort of long vision that we have a lot of patients still suffering. And so therefore we need these programs to help them, especially with the long COVID. We do need some more help there. But even in terms of the prevention, just simple things that we can do for our patients and the vaccination strategies. And we're going to hear about RSV vaccination. So there's going to be a good vaccination strategy, but we just need to help patients understand the importance of these programs and what they can do to make sure that they're protected. And don't forget that you can sign up for the expandcourses.com, where you'll be able to find recordings of this webinar and any other new material that might be coming up as well. And so basically, as you can see on here, lots of people worked on this. Mike was our encyclopedia. Not only is he an encyclopedia, like he gets stuff done, right? Like, we anything that we don't want to do, Mike always volunteers. We don't even have to force him. He actually volunteers to do all the heavy lifting. So Mike, thank you very much for all the work that you've done. You see some of the names of the other people that have worked very hard. And we want to thank Respiplus and all the sponsors for having the vision of saying, let's create a place where patients can go and get proper information, and ourselves as healthcare providers can have a resource that we can pass on to our patients so that they can manage this alongside us, because we always talk about partnerships. In this condition, COVID-19, we need a lot of partnerships with our patients in order to make sure that they continue to live well beyond COVID-19. And I think the title is actually very appropriate. So Mike, thank you very much for joining us.
Peter.
And thank you for all your hard work. And thank you to the Respiplus team. Take care, everybody. Have a good evening.
Take care. Bye-bye now.